Good afternoon and welcome to the Macdonald-Laurier Institute's webinar entitled A Better Path, Building a World-Leading Health Economy in Canada. My name is Tasha Carradine, and for those who don't know me, I am a principal with Navigator Limited and a National Post columnist, and someone who's been very interested in this issue for, I would say, my entire career in media and journalism. I'm going to be moderating today's discussion with a panel of some of Canada's leading experts in the field in both healthcare and economics. But first, I'd like to thank the Macdonald-Laurier Institute for hosting this event. Believe it or not, they are now in their 10th year. And in that short time, though, they have established themselves as the top federal public policy think tank in the nation's capital, with a growing program in foreign affairs, national security, Indigenous reconciliation, economics, fiscal policy, criminal justice, and much more. The Institute's also, for several years, sought to create a lively national debate on the subject that we're going to be talking about today, how to foster innovation in healthcare and related industries for both the well-being and the prosperity of Canadians. Now, it's no secret this topic could not be more topical, really. I mean, every day there is another headline, whether it is about the COVID vaccine, its availability, tests, treatments, where are those at, the issue of medical equipment and the capacity of our healthcare system. Also, though, innovation in our life sciences sector, and most recently, the banning of mass exports of prescription drugs to the United States in response to the order by the former president of that country. Where's all this going to take us? Canadians are extremely concerned right now about access to vaccines in particular. They're worried that since they won't be made in Canada, we're not going to be front of the line. And they're wondering also about treatments that are being developed and when we're going to have access to those as well. But the bigger question, too, is when the pandemic is over, where are we going to be positioned with regards to health services? We know that waiting lists are getting longer and longer. They were long before the pandemic. Now you've got elective surgeries increasingly canceled and postponed. How are we going to take care of patients who need timely care? The events of the last year have really made it exceedingly clear that a thriving healthcare sector is critical for our nation's health and well-being and our economic progress as well. It's a sector that really could help drive the economic recovery if we allow it to do so. Too often, Canadian policymakers sort of get in the way of things. They act to inhibit innovation instead of encourage it in what could be an even more booming field. So can we do better? That's the question we want to ask today. Can we capitalize more on all the great ideas and incredible minds that are out there innovating and working on these problems in Canada? What would it take for us to become world leaders in the life sciences and healthcare fields? Joining us today are some of those great minds, a great panel that we have assembled, and I'm pleased to introduce them. They're going to be speaking with us and helping us answer, or at least try to answer, these vital questions. First off, we're going to hear from Jack Mintz. He's one of Canada's most respected commentators on economics and public policy. Jack is an MLI Distinguished Fellow and President's Fellow at the School of Public Policy at the University of Calgary. You are also going to hear from Audrey Laporte. She will be well known to our audience as a professor and government advisor. And heading a very long list of qualifications and affiliations, Audrey is the director of the Canadian Centre for Health Economics. Jason Field is also likely a familiar face to many watching today. He's a research scientist and CEO of Life Sciences Ontario, which represents industry and stakeholders in the fields of biopharmaceuticals, agriculture, medical devices, environmental technologies, and more. And finally, Richard Owens is a senior fellow with the Macdonald-Laurier Institute and a lawyer who is specialized in business and commercial law, intellectual property, and technology. And Richard also teaches intellectual property law at the University of Toronto. So, to format, our speakers are going to each have 5 minutes to introduce themselves a bit more and make their opening remarks. And then we're going to proceed with a moderated panel discussion, and we'll have a chance, of course, to take questions from you. For those who are following on YouTube, please put your questions into the discussion there. We'll get to as many as possible. We already have some people lined up, so we know people are excited to hear about this. So let's start off with Jack Mintz. Jack, the floor is yours.
Thank you very much, Tasha, for that introduction as well. Let me just say that, one of the things that people raise, like, what's the most obvious thing that we should learn from this, pandemic experience that we've just had? And many people would just say, we weren't very well prepared. That's true, no question, but, that's also true for many countries. We're not the only one that was like that. But what I find most interesting is to ask the question, how well did we respond to the crisis in terms of getting things done in order to minimize the waves that took place, not just the first time, but the one that we're now going through right now. And I put some numbers together, but it does sort of suggest that some of the problems that we've had in the system for many years are appearing now. Even though we are a good spender in healthcare, it's 11% of our GDP. And in fact, only Switzerland and United States being more than us. In fact, we're above the OECD in spending. But as many studies, like the Commonwealth Fund studies have shown, Canada is mediocre in terms of what it achieves. And there are things that we have not done very well during this pandemic. For example, I checked testing numbers today, just before. And Canada is doing about 1.98 tests for every 100,000 people. United States is double that at 3.92. The UK is more than double, actually. UK is 4.38. Germany is 2.3, also higher than us. That's an indicator that we have not done as well. We are not dealing with this as fast as we could. When you look at vaccine manufacturing, as another example, the top 10 manufacturers in the world, 6 of them are American companies, 1 Japanese, 1 UK, but there's 1 Australian. And Australia is a smaller country than we are. And there's 1 Danish one, which is also smaller than us. And so you have to ask the question, why is it that we can't get a big pharmaceutical company operating in Canada that would be significant when you have some small countries that are able to do that? Our R&D in the pharmaceutical space has been dropping. In 2007, and putting it in 2017 dollars, we spent $47.50 per capita. And today, in 2017, we spent $23.70 per capita. In other words, it declined by 50% spending on R&D in the pharmaceutical space in Canada during that period. And then we have, and what has been well known is that we have a poor integration of services in Canada, and this really showed up in the long-term care and the home care areas. We don't have enough people with good home care services. And part of that is the way that we've set up Medicare in Canada, where it's focused on hospital services and physician services. But when it comes to the other aspects of healthcare, we do not have an integrated system like in the United Kingdom and elsewhere. And maybe we'll get into that later on, but I'll stop there, Tasha.
Okay, thank you so much, Jack. And yes, home care is one of the big issues Canadians are talking about in the context of healthcare as well. Let's hear now from Audrey Laporte. Audrey, to you.
It's a real pleasure to join my distinguished panelists and the participants in this podcast today to talk about this very timely subject matter. So there's been a lot of suggestion recently that somehow or other we should be guaranteeing our access to vaccines by producing our own. And a lot of this discussion has cropped up in the context of COVID. But if we're talking about made in Canada, even for COVID, are we talking about manufacturing just one vaccine or all of them? There are other important, even vital drugs. So are we aiming for self-sufficiency in manufacturing all of those? Autarky in drug or vaccine production doesn't make much sense. What COVID has made clear is that we need strong international agreements to create broad markets and markets which will support a number of alternative producers, like the different producers of the COVID vaccines. In addition, if we try to become self-sufficient in building manufacturing facilities, even for one of the COVID vaccines, it would take many months. And that's not feasible right now anyway. But if we did, supposing we did have a plant, what would we do if COVID hit workers in that plant? What the whole COVID episode has also made plain is that pharmaceuticals are a worldwide industry. And to ensure our access to vital drugs we have to look to secure multilateral agreements. This is a case where it doesn't make any sense for Canada to try and go it alone. For us to be truly secure, we have to be part of an international system. And moreover, recognizing how precarious our position may well be, Canada could take the lead in establishing international rules for production and supply of things like COVID and other vaccines, because the economics of vaccine production do not always support trying to manufacture any or all of them at home. Thanks.
Thank you very much, Audrey. And yes, that's another hot subject for discussion. A lot of people have already sent in questions. Why doesn't Canada have a made in Canada vaccine production facility? So we'll hear more from our panelists on that, I am sure. Let's go now to Jason Field. Jason?
Thank you, Tasha. Here at Life Science Ontario, we've been advocating to policymakers for many years about the importance of investing in life sciences innovation. And while this pandemic has been devastating for many Canadians, patients and businesses, it's also shone a spotlight on the need for this continuous investment and the need for policies that will support an even more resilient health system here in Ontario and across Canada. And certainly the recent conversations around access to vaccines and PPE supply chains are prime examples of this. In the decades leading up to COVID-19, the health policy direction in this country has been solely focused on cost containment. And a prime example of this are the recent changes that were made to the Patented Medicine Pricing Review Board, or PMPRB regulations. And they were extensively criticized for their potential impacts on the health research ecosystem and to Canadians' access to medicines. Our organization has done some research on this, and we've confirmed that it is having impacts into the availability of medicines here in Canada, clinical research, and life sciences jobs. And this is all driven by Health Canada's policy direction to essentially commoditize health innovation. But of course, when COVID hit, that policy approach was kind of set aside for a moment, right? Governments opened up their coffers to, support economic and health responses, and rightly so, to the crisis. And Health Canada even made COVID-19 vaccines exempt to these PMPRB regulations. And in doing so, actually admitted that these regulations serve as a barrier to access to medicines. But these regulations are still coming into effect January 1st. And for patients with rare diseases and cancer and chronic conditions, there's still going to be a barrier to new treatments. So in terms of health policy, it's not easy. It does need to balance affordability and value with access and innovation. And this can be achieved, but I think what's become clear is that it hasn't been achieved here in Canada and that we need to do better. And then maybe my final thought before I pass it over is someone said to me the other day that the final symptom of COVID-19 is going to be memory loss. Pertussis vaccine, those are for infants. So we do have some capacity, but I think the take-home message is, and what all of this is pointed to, is that we have created an environment that hasn't been friendly to attracting these types of investments on an ongoing and continuous basis. And so while we have these pockets of success stories, we really need to have a thriving life sciences ecosystem, and that brings inherent value to our economy and to our society.
Richard, what would you say from the list that you had enumerated? There's got to be one that stands out in terms of, I guess, a challenge we didn't anticipate. I mean, a lot of people say, we were stockpiling PPE for quite a while after SARS, and then, oops, forgot to do it. But what could we have done better in this pandemic?
Well, I can give you a one-word answer, which is everything. You're right to also highlight the border control issue, and it's worth remembering that the Minister Blair repeatedly in the House assured Canadians that all necessary steps were being taken at airports, which was completely fanciful. I mean, it simply wasn't true. just briefly, I think probably the biggest thing is we've got to be prepared. And part of being prepared is having adequate hospital capacity. In Ontario, we have the lowest hospital capacity in the OECD. We had negative beds available. People were being treated en masse in hallways. And so a pandemic comes along, we can't treat anybody. So we're forced into a lockdown. We have no strategic wiggle room at all to develop the strategy. And if you're not prepared, you at least have to be nimble. Well, it's 9 months later, and we all know how nimble we've been.
Yeah, not particularly in some cases. And I think, to go to Audrey's point about gaps too, one of those gaps was not simply in the provision of healthcare, but the supply chain as well. Huge issue. And Audrey, I know that you have a lot of views on that in terms of the gaps for either with testing, vaccines, or any of the other supplies that we needed to combat this pandemic. What have we learned about our supply chain that we could do better in future?
Well, I'm going to pick up on some of the themes that have been raised here. So we know that the health sector, as most people think of it, has a whole mess of elements in it that have been affected differently by the pandemic. And Richard just noted that one of the immediate impacts was on healthcare delivery. And that's where, we've been warned about hospitals running out of capacity, and non-COVID treatments have been canceled or delayed. And to a very significant degree, the reason things have got and are still getting so worrying is because governments at federal and provincial levels have been cutting down on capacity in the name of cost control for decades. And as has been noted, many of our hospitals, even in pre-COVID times, were routinely running in excess of 100% occupancy or capacity. And governments have not seemed to grasp that the only kind of inventory a hospital can carry to meet unexpected surges in demand like we're experiencing right now is to have unused capacity. And they've either assumed that we're never going to have a surge like this in demand, or that it's going to be another government's problem. And the can that was kicked down the road has come to a stop here. And so we need to change that. So if governments are serious in their discussions about infrastructure spending to get us back on track economically, then they may want to think about spending on healthcare delivery capacity, and that they hope never to fully use. But that would probably be a good place to start. And it's a form of inventory spending that would be distributed across the entire country. So, perhaps we need to go back to the era when the feds were giving provinces money to build hospitals, except we need to think about investments in the healthcare sector, and in particular in the infrastructure capacity. On the health sciences side, we've got separate questions here, questions about research and about production, and those are different things. Because drug companies are going to set up production wherever it's more profitable for them to do so. The factors which affect where they'll do research are different from those which determine their production location decisions. And I know that my colleagues are going to be talking about elucidating some of the contextual factors that promote decisions about research and development investments. So I'm going to focus perhaps here in relation to this question on the production capability piece, because there's been a lot of talk about how we need our own vaccine production capability to enable us to meet population needs, and talking about a secure supply. The risk with that kind of talk is that we could fall into the old national defense arguments for subsidies and protectionism. And The fact is that reliance on a global supply was not the source of the problems that we've just talked about in terms of getting hold of PPE. It was that we were dealing with, monopoly suppliers of key products. And, as Jack pointed out, we're never going to be able to meet our own demand for everything, which could be regarded as a vital drug, paradoxically, because our market is too small. So building that range of productive capacity would drive the cost of drugs through the roof. And, being self-sufficient wouldn't resolve the pandemic issue. Because if, as I noted, if you depend on a single factory, a single supplier, whether domestic or foreign, if the virus gets into that plant, your supplies have come to a halt. So if we're serious about pandemic proofing essential drugs, ensuring that supply flow, and this goes for PPE as well, we need to have geographically dispersed production where each plant has sufficient excess capacity so that it can pick up the slack if any one of the regions in which they're located is hit. And of course, carrying that kind of excess capacity is going to raise the fixed cost of production. And that's even when that capacity isn't used. And we have to face up to that squarely because it's going to raise the cost of drugs, even in a non-crisis situations. The other thing that geographic dispersion does is that with the different production plants, you're operating under different sets of regulations. You've got to meet different country standards. So there's no point in having multiple possible sources of supply if your country cannot, has regulations in place that prevent those products from being imported into your country. So in other words, the geographic dispersion, which I'm arguing here is essential for, the maintenance of flow of essential, goods and services and drugs, et cetera, needs to have the force of an agreement on production standards and inspection regimes. And, this is particularly true for vaccines.
Audrey, I want to get everyone in the conversation too.
I'm sorry.
You made a lot of good points, and
I'll stop there.
No, there are two separate debates actually. Before we continue, though, I do want to address our viewers, our patient viewers, because we know we dropped off for a little bit there. We apologize. It's a power outage, and that is beyond our control. But we are back now, and if you want to see the portion that you missed, it's all been recorded. Power didn't fail on that, so it will be available on the MLI website afterwards to catch up for the segment that you may not have seen live. But continuing our live conversation, I want to pick up, Audrey, on that very important piece of the access to vaccines and the issue of domestic production or not, the geographic piece you mentioned, because that I think is really the number one issue on Canadians' minds and on our politicians' minds. And we know that what makes sense economically is not always make sense politically. So I would ask, are there panelists that want to weigh in on that? I don't know if anyone wants to lead on a response. Do we need made in Canada vaccine or not?
Maybe I'll just bring in a little bit of economics here, and many of the things that Audrey said, I totally agree with. There's something called comparative advantage, and that you sometimes end up doing the things that you specialize best in. But I do want to raise 2 points that are kind of relevant to that. The first point is that we actually do have innovators, people who produce medical equipment and things like that. And when I was on the panel that was appointed by Honorable Rona Ambrose back in 2014-15 to look at innovation in healthcare, we had consulted right across the country with a lot of the innovators. And it was a very interesting story that they told us, and that is that they were exporting to other countries. They had no difficulty in exporting what they could invent, but they had a very difficult time with formularies in Canada because the provinces, with their cost effectiveness as a goal, as opposed to looking at cost benefits, which means you look at the beneficial side of whether it's drugs or equipment or whatever, when you have this focus on cost benefit, you end up saying, well, will this invention actually lower my costs, even though it could have very significant benefits, but will it lower costs? If it doesn't lower costs, we're not going to do it. And that actually does hurt the innovative climate here in Canada. And the reason that can be important is that it's important to have some domestic activity going on and your own scientists in working in an area, because then they can also communicate and work with other scientists in other parts of the world. So having some domestic capacity is important. And we have to, I think, take a very different attitude to the way that we arrange our system so that we can get more innovation. Because right now we are not being able to do that.
Okay, I heard the other voices chiming in too. Jason, do you have a comment to make on that?
Yeah, absolutely. I think Jack nailed it. You know, I don't think that Canada can ever expect to make everything here, whether it's a vaccine or PPE or you know, you name it. But the question we should be asking ourselves is the innovations that we create here in Canada. Why aren't we able to see those adopted into our own health systems and to reap the benefits of those innovations? And then within those global supply chains, what's the significance of Canadian innovation within those global supply chains? So we can do better, and we can have more influence into where those investments come if we have an environment that is attractive for those types of investment and are attractive for innovators to innovate here in Canada.
Yeah, and I just want to chime in here. I agree with that, but I would just say that to encourage the development, we want to be wary of falling back on protectionism, subsidies, and handouts. And, you know, people talk about government grants to the auto sector, but we've seemed to have lost sight of the fact that the only reason we have a viable auto sector is the pre-NAFTA Auto Pact. Without that, we were building cars for a small market, paying high prices for them, and it wasn't attractive to invest in Canada. And subsidies and things like that aren't going to do any good. So all subsidies do is raise prices by stealth. The bit you don't pay at the cash register, you pay through your taxes. So if we want, what I'm saying is to encourage, to have production in Canada, the most important thing we can do is create an international agreement, like a pharma pact of some sort, to expand the potential export market. Otherwise, we ain't got much to offer to make us an attractive place to produce.
Except I would just quickly add that regulations, I always like to look at policies that get in the way of something. And so I totally agree with you, Audrey, about subsidies, absolutely. But I think that some of our regulations, and I think Jason already talked about this, but price regulation, if we're going to end up making it difficult for pharmaceutical companies to come here, that's a problem. And as Richard talks about, if you have intellectual property regulations that deter companies from coming here. In fact, I heard of one case myself of a large pharmaceutical company that wanted to come to Canada. And because of our IP rules, they have turned it down. We missed a multi-billion-dollar investment for that reason. So, you know, there are things that we could do to help build that capacity. That's not a matter of subsidies, but it's a matter of governments improving their policies.
I agree on the subsidy side of things. I don't think we need subsidies. What we really need is a mechanism within our health system to realize value. And I think that's missing because a lot of the budgets within the health system are siloed. So you're asking one part of the health system to invest in innovation, but it's not being realized in that budgetary silo. And there needs to be mechanisms to really realize the value of these innovations. That's the fundamental change that needs to take place.
Okay, I'd like to get Richard in on this because I know, Richard, you also in your opening remarks mentioned the PMPRB and the changes there to drug pricing, which will have an adverse effect on the availability of new medicines in Canada. So offer us your perspective on what everyone just said in terms of vaccine production, a vaccine deal with other countries. Is that the way that we should go?
Well, it probably is. Happily, I'm not in the position of investing large sums of money in vaccine development. But I can only say I completely agree with everything that the panel has said so insightfully. Clearly, it doesn't make sense to adopt a Made in Canada strategy, but neither does it make sense for us to be as vulnerable as we are. And we need to address the issue of vulnerability through a mixture of domestic capacity and contributions to capacity, as Jason so aptly said, and through robust international agreements. If we're going to have those agreements, we need to be able to contribute to the development ecosystem, not be the penurious absentees that we are now. One other dimension to the supply problem I'll just quickly mention is that there is a strategic dimension here too, or a defense almost dimension. We rely on China for almost all the ingredients to our small molecule drugs. We rely on China for all of our supply, steroid supply. We rely on China for 96% of our antibiotic supply. China has a not great stance to us at the moment. We're basically at war with China. It's not yet come to shots, thankfully, but they're clearly opposed to us. They have a great and very effective, albeit not very well contained, biological warfare research program. And relying on them for the cures to weapons that they may be preparing to use against us, far-fetched though that may seem, is an entirely sound policy. So, and in any event, allowing them to monopolize the global market just for purely economic reasons is poor. So I just wanted to throw that sort of global strategic dimension into the mix as a further impetus to develop the systems and capacities that the panelists have so aptly described.
Yeah, I think, Jack, you have some views, I know, on the sort of intersection between economic, healthcare, and also other issues, political in particular, such as strategic and defense issues that have come out of the pandemic. Do you think that these are being juggled appropriately, or, as Richard said, the red flags are there, maybe we're not paying enough attention to them?
Well, I think the concern I have just generally with public policy right now, in terms of the way we're thinking about our COVID period and our post-COVID period, is that we're kind of meshing two sorts of issues together. Right now, we're in the COVID period. In fact, we're in a wave now again, and we have further health restrictions that have been imposed. And that's going to have economic short-term impacts. And so we need to think of policies, first on the healthcare side, obviously, in terms of testing and tracing and putting resources in it. In fact, we should have done this for actually quite a while now, declaring all-out war. And in fact, even manufacturing facilities for vaccine, the federal government put $12 million into Saskatchewan and $40 million into a Quebec laboratory manufacturer. Maybe there weren't other opportunities, but I'm astounded that we can pay $1 billion as an auto subsidy during this period when we should be just going all out to have done all sorts of things in order to have the capacity that we're going to need to deal with COVID. And then on the economic side, we're doing the right things in helping the population, although I would argue that we've probably gone overboard when people's personal income went up more than any other OECD country, went up 12%, $5,400 per capita during the second quarter because government transfers were more than the economic costs, which of course makes it tougher with budgets when we're not putting money perhaps in the priorities that we needed. Now, though, that is still the agenda right now, and it's going to be the agenda for this coming year. And so when you start getting into longer term issues, I think that's something for next year's discussion, in my view. And we should not start trying to focus or take the focus away of declaring this all-out war on COVID, both in terms of health and economic effects right now.
Okay. Does anyone have anything to add to that sentiment? I mean, COVID is the focus, obviously. Can we keep an eye on the longer term, though, in terms of not necessarily other issues, but I'm thinking, drug pricing, for example, to come back to PMPRB regulations. They were delayed, as Richard said. We know the impact on them may not be on the immediate situation with COVID per se, because they're exempt. Obviously, vaccines are exempt. But in the longer term, that is a debate that's being had now. does COVID teach us that, in fact, we're on the wrong track when it comes to pricing these medicines? Audrey, I see you nod.
I'll just throw something in here before I throw it over to Jason and others, is that, prices are the way that a society signals value, the value that it attaches to a particular product or an outcome. And these, very research-intensive, dynamic, for-profit companies will aim for those targets that we signal are most important, that because those promise the greatest value return to them. And we've got problems not just on the brand name drug side, but there was just an article in the Canadian Medical Association Journal talking about the fact that of the 9,000 or so drugs that we need, a quarter of them are in shortage situation right now. And shortage is associated with being generic, being a generic drug, and having a sole producer. And so the policy of putting downward pressure and having a cost focus is not only affecting the availability of the cutting edge brand name drugs, but it's permeating right down through into the generics. And that's why we're seeing shortages, and we're not seeing, antibiotics and other things coming on stream the way they have had in the past. And that's something, as drugs become more and more important, this is going to be a major issue that we can't run away from.
No, we can't. Go ahead, Jason.
I'm really worried about this as well, because we've been fighting this battle for decades over the arguments of cost versus value. In times where we were, in economically decent positions, and now look at where we are with all that we've invested into COVID and the economic situation we find ourselves in. Post-COVID is going to be a tough time for governments to come to terms with the fact that they need to continue to invest in health and life sciences with their fiscal situation. So this is still going to be a tough argument to make, even though we've lived through a disastrous health and economic crisis. That worries me tremendously. And in terms of PMPRB, those regulations don't really address the fundamental challenges that we're seeing, which is that drugs are becoming increasingly costly because the science is advancing. They're becoming more personalized. They're becoming more rare disease-like. So, and we've heard the government talk about a rare disease commitment, but it's a commitment. It's down the road. That's the problem that they need to start thinking about. And if they can start wrapping their head around that, then they can start wrapping their head around how to invest in the medicines of the future, because that's what they're going to become.
Richard, I see you nodding. You want to chime in on that?
Yeah, please. I think Jack, Jason, Audrey, you're exactly right. I mean, we're focusing not on the value that drugs are delivering to us. We're focusing on the price, and increasingly with perverse policies like increasing the PMPRB's lockdown on drug pricing. We're emphasizing cost control over the health of Canadians. The lessons from other jurisdictions, and indeed from Canada, both recent in terms of recent data and longer term data, are very, very clear. To the extent you drive down prices, you ensure that drugs aren't registered in Canada, they're not imported into Canada, and supply dries up. And if we want top-notch healthcare, increasingly we're going to have to go down to the United States, because the drugs we need, the cutting-edge new pharmaceuticals, simply won't be here. Ask somebody from New Zealand how many people go down to Australia for care now, for instance. So our policies are actually perverse. And just on the capacity issue, which the other panelists touched on, we're just very bad at setting priorities. Facing the possibility of a pandemic, which we've all known we've had to prepare for a very long time, what have we done? We've spent, in this province at least, enormous amounts of money blighting the landscape with large things that chop up birds and enrich South Korean industrial conglomerates, windmills, and their ilk, with no impact on energy supply other than raising the prices to the point where pensioners can't afford to pay their heating bills. while staring down the fact that we have no available hospital beds. We need to reconnect our public service and politicians with the real needs of Canadians, as opposed to these flights of policy fancy, which leave us begging in the critical areas we need.
The Don Quixotes of our politicians, hopefully are listening to you. I don't know if they are, but you actually, in terms of policy initiatives, I want to move a discussion to one that is very much being discussed as well, that was pre-pandemic, but is still in the offing, and that's pharmacare. Many people say that PMPRB regulation changes were designed to pave the way for a national pharmacare program. With the situation now as it is with our healthcare system, with spending through the roof, Jack, is there space for national pharmacare in our discussions anymore?
No, I think national pharmacare isn't worth it, and is not the priority right now that we have as a country. Yes, there are 10-15% of the population that we want to make sure can have drugs that they needed. But you don't need to blow up a whole system in order to deal with 10 to 15% of the population. A large number of people are on their employer-provided healthcare plans. There's the senior plans, of which I qualify for one, that we are able to have free drugs given to seniors in many of the provinces, or certainly at a very low cost. And so we have taken care of a large number of people. And when I read the Hoskins report on pharmacare, it's expensive, but one of the items for making it cheaper is to tell Quebec to cut back their formulary of drugs. Now that's going to go over really well, and I don't think that's going to happen. So I don't think when you start getting down to the federal provincial side of it, we don't need another cost sharing program with the federal government doing that. But if the federal government wanted to provide support, and this is a recommendation I worked on myself, I think that the federal government should completely redo its medical expense credit, which is frankly complicated and a lot of people don't follow and keep receipts, but instead look at having a refundable tax credit to help the very poor, and other lower income, let's say middle income, but at the lower end of what we might call the second quintile of the population, with drugs, and the cost of drugs through a tax credit, and that's quite feasible. In fact, if we got rid of the tax exemption for employer-provided benefits for healthcare and dental care given to individuals, which mainly help upper and middle income Canadians, we could pay for a very generous tax credit that would help offset the drug costs without having a national pharmacare program. Where the argument is made for having some cooperation amongst the formularies is to improve their ability to negotiate lower drug prices. But that's a different thing than having a national pharmacare program. And so I think we're just going off on the wrong track. I think we have bigger issues to deal with than pharmacare. And that's why I made my comment earlier on about home care and long-term care. I think that's a far bigger priority down in the future in terms of helping people when they get older and having a place that they'll be happy to live in as long as possible, before needing extra care. And so I think that long-term care, home care issue, I think is a much bigger priority. And I think COVID has now really put that much more at the front burner of issues that we need to deal with in the future.
I see a lot of nodding on that. Assuming nobody disagrees, does anyone have anything to add to that piece of how COVID may change our approach to LTCs and how the life sciences industry might be affected by that?
Yeah, on that front, I agree with everything Jack said about national pharmacare. I think the only reason it's even being discussed still is because we have a minority government that is trying to stay in power and use it as a political bargaining chip. But I think post-COVID, we're not going to be in a financial situation to afford the type of program that was being proposed by Dr. Hoskins. And I don't think that there's any appetite by the provinces to do so, because long-term care has become the priority. There's a greater vulnerable population there, and that's become an emergency crisis in and of itself. I think in terms of the life sciences sector, one of the things that our members want to see is the same thing they want to see, across the healthcare system. How can we get the innovations we're making here in Ontario, and they're significant, into the hands of the health system and to these long-term care facilities to improve the lives of patients and residents? And a lot of our members are lined up to do that. They're willing to help, but we need to strengthen that public-private partnership and bring, industry to the table to have the discussions in terms of how we can improve things.
Okay, well, you actually Audrey. Sorry, Audrey. It's kind of asking the same question, so you'll have a chance to answer it, because it segues. I want to get to some of the viewer questions now that we have to ask, and it dovetails with one of those from Reese, who wrote in and said, is there an opportunity in Canada, once the pandemic passes, to look at a broader life sciences industry strategy for Canada? So to build on what Jason just said, Audrey, do you want to take that one on?
Sure. If you mean by that, as I've said before, I'm going to be a little bit of a contrarian. One means subsidies and things like that. Then no. But can we look at the regulatory structure? Can we look at the tax system as a whole and make sure that it's not standing in the way of innovation generally? Then yes. Otherwise, we want to get out of, the business of government picking winners, because we know that doesn't end well. It doesn't end well for, the industries and producers that are not picked as the winners, nor does it tend to end well for taxpayers, who usually end up holding the bag. But I do think that Jason has raised some critical points. That can we have elements within a publicly funded system that incentivizes innovation, and innovation that brings maximum value to the Canadian population? And I think the answer is yes. We've had examples, for example, in the UK, where they had physician fund holding, where doctors controlled the budget, and if they saved the system money and met outcome performance measures for their patients, they got a share of the value proposition that they created. And we could think of elements of our system bringing in an innovation kind of incentive, so that providers and actors within the system that generate value, real value in terms of improved outcomes for patients, get a share of the value that they create. And the rest stays with, the Canadian system and the Canadian population. And I think the other thing that we need to think about is fundamentally how we fund our system. Because we're constantly in an emergency. It's, an aging population. A pandemic has hit us. We're constantly out of sync with, the money we spend and where the need is. And I think we should start thinking about not a pay-as-you-go system that we have now, where it's the young or the younger working population that is financing the care for people who are now retired or otherwise need health care. We should start thinking about a more, insurance design, where you pay in when you're young, and it's to finance the care when you're older. So it doesn't matter if there's a mismatch in the age distribution. And we don't get into this cost-cutting crisis cycle, which rotates from different groups in the healthcare system. Sometimes it's doctors that are responsible. Sometimes it's drug companies. Sometimes it's patients that are accused of being high cost and costing the system. And what we have to do is get to long-run strategic planning and a structure that supports that.
Could there be more room for the private sector in that structure? I'll throw the question out, because it actually goes back to something you said earlier, Audrey, as well, which is the capacity piece. In terms of building capacity, we know governments are going to be strapped for money. Is this a moment when we have to, look at the elephant in the room, which has been there a long time, that Canada insists on having a purportedly only public system? We know there's a lot of private stuff on the edges, but do we have to say, let the private providers in so that we can build that capacity. Governments can't do it. Who wants to take that on?
I can. I'm happy to jump in, just in part because I can do so from some of my personal experience. I think there are lots of little tweaks where we can admit some of the entrepreneurial energy that is waiting on the sidelines, that not only can quickly augment the capacity that we have in our system to respond to the health needs of Canadians, which in the face of COVID have become dire, but which in turn, by providing a sort of more competitive environment, will actually lead to better and quicker evolution in the public system. I think that Jack's idea of a tax credit is a fabulous idea. I think that less federal dictation of the policy environment in the provinces would actually be helpful. I think that we need a small amount of some small copay for visits to the doctor, which would provide some discipline to the system. By all means, subsidize the poor, but make it a little bit costly. Perhaps medical savings accounts could be very helpful. We need to embrace private insurance. But from my time in practice, I saw just incredible energy going into some of the less regulated colleges where efficiencies and scale were being introduced, and entrepreneurial energy and marketing and quality control brought to dentistry and physiotherapy, pharmacies, other areas which don't have quite the same socialist lockdown that our main care providers do. And I think that if we were to allow private insurance, as indeed the Supreme Court of Canada has long legally obligated the government to do, we could bring some of that entrepreneurial energy in, fund a rapidly growing private healthcare sector that would do a great deal to relieve the pressures we've got on our private system. I was even briefly involved in the ability to deliver private care through an Aboriginal reservation, and indeed somebody has taken advantage of that. So as I say, there's this push, this knowledge that it's a very specialized, very potentially revenue-rich market that it's folly to exclude these people from. Brian Day, leading this lonely fight in British Columbia, is a martyr to the interests of Canadians, and we should be taking up his cause.
I see some nodding. Jason, would you like to add something?
Yeah, I mean, this is very tricky ground when you're talking about the Canadian health system, right? And it's sort of sacred land we're treading on. But even in the constraints of our public healthcare system, industry has a significant role to play that it has been unable to play for the most part, because there's this butting of heads between the procurement bodies and the private sector. And a lot of these industry players are people that live here in Canada. They have their families here in Canada. They take full advantage of the health system here in Canada, and they care about it. And we need to harness some of that power. So that relationship, I think, between the private and public sector does need to shift. And there's a lot to be offered by the expertise in the private sector. And I just want to, talk about a couple of other things. In terms of a strategy, an industry strategy, the work's been done. The federal government had the Health and Bioscience Economic Strategy Table, which was a phenomenal group of thought leaders. And I thought they did a great job of putting recommendations together, most of which have basically not seen the light of day. So, the work's been done. We know what the issues are. We know what some of the solutions are. It's just a matter of political will and to move them forward. And then just one last thought, and Audrey, I don't want you to misconstrue, my passion for Made in Ontario, Made in Canada innovation as a advocacy for subsidies. I dislike subsidies as much as you do, but I am equally as frustrated as Jack mentioned when I see innovator after innovator from Ontario, from Canada, who are selling their innovations around the world, providing value into those health systems, and we're not able to capture that here in Canada. And to me, that's a broken system that needs to be fixed.
But I agree with you, but I think you've pointed to some of the solutions. I mean, I think raising the specter of private healthcare is touching the third rail, and that is going to distract when there's a lot of low-lying fruit that we've talked about within the system as it is, taking it as it is, where there would be a reason for producers here to bother trying to innovate and introduce innovations in our system. And if we did that, and then, this idea of creating markets, enabling markets for the producers here so they don't have to go to the States. They can stay here and still have access to big markets. I think that's kind of the way we should be thinking about this.
I just want to add one more thing that hasn't been mentioned yet. And that is, and I've been dealing a lot with startups and companies that have been, like high-tech companies that are starting up in Canada. What often happens is that they get up to a certain point and then an American producer comes along and says, boy, you've got a great innovation. I'm going to buy you out and take you down to the United States, and all the spin-off jobs and everything else happens after that in the United States,
yep.
Which has been a common thing, and I won't go through all the aspects of the tax system, but we have a tax system that basically encourages that through the lifetime capital gains exemption, because you can cash out and get your exemption at that point. Through now high personal income taxes, we now have one of the highest in the OECD, over 50%. When the rates are 5-6 points lower in the United States on average, and we don't have any incentives for people to do IPOs in Canada like in the United States. We need to also think about our tax system too, in terms of how we can capture the returns on innovations that are started here, often with government funding through various government grant programs and R&D tax credits, as well as support that's given to the university sector that often gets into these high-tech companies. And then we end up losing a lot of the benefits. And that is an issue that really needs to get addressed at some point. But that's a longer-term issue, I think, and it's been around for many years.
And I think that point underscores, because we get lots of little, small startups coming, and a few of them even hit medium size. But to become an apex player in this capital-intensive sector, you need serious coin. And the fact that we have all these startups happening is testament to the fact that we have talent in this country. We have phenomenal talent in the public, private, and parapublic sectors. And the issue that I think all of us have been talking about is the environment in which these talented people find themselves. And if they can't make it here, they will go somewhere else where they can. And it's a tragic loss for this country when we see the talent leaving, and they take with them jobs and et cetera, and wealth that could be left here and could be, improving the quality of life of all Canadians.
Okay, well, that actually brings us to a question from Almas, who wrote in a similar vein. How do you recommend that Ottawa, and you could say all political levels, but Ottawa in particular, move away from an antagonistic approach dealing with pharmaceutical manufacturers and innovators, presumably, towards one that is more cooperative? What would you advise our political leaders to do?
I think the first thing to do is to stop the PNPRB regulations in their track. That is just a draconian policy regime that targets that industry in a way that's going to have ripple effects across the life sciences sector and to patients. So number one, put the brakes on PNPRB and then build on the good dialogue that you've had with the industry during COVID-19 crisis. There's been unprecedented public-private sector collaboration. That's something to build on.
Okay. Richard, would you like to add to that?
Yeah, so I think it's a really interesting question. I mean, we're effectively this culturally monolithic monopoly, if you will, with a history of antipathy to the pharmaceutical industry, and in particular to exclusive marketing / patent rights in the medical field. And we're not unique in that. There are many countries that, long, like Canada, did not allow patents for pharmaceuticals, or that once allowed them grudgingly to comply with TRIPS, and has since thrown every roadblock in the way to actually exploiting the pricing power that we're obligated by treaty to provide to pharmaceutical inventions. So this goes back a long way. How you manage a cultural change that flips you from industry bad, cost control good, over to we need to invest in the health of Canadians, and innovation with all of its unpredictability actually makes us all wealthier and healthier, and we really should be pursuing that policy. Productive, constructive approach to the market instead of one of fear and lockdown and central control. I don't know, but I think it needs to be that fundamental. And I think I'm not without hope, actually, because I do think it's there. It's plain for everybody to see. We've made these stopgap steps since the late 20th century to go from no pharmaceutical patents into this regime, which was politically driven to create the PMPRB. It's not like there's anything ineluctable about its existence. It's there to sell the NAFTA enlargement of pharmaceutical patent power. So we just need to take the next step and think, well, wait a minute now. Is this policy serving the needs of Canadians? And the answer is no, it's not. And by simply walking off the end of that pier and stepping into the water, we'd find it's not so bad. We can actually be players, and we can pay a fair price for pharmaceuticals, and we don't need these expensive policy solutions, which are actually perverse and destructive in their consequences.
And Richard, in all those trade agreements, Canada had an opportunity to take on a leadership role in terms of data protection and patent term extension, et cetera, et cetera, et cetera. And we have strived for mediocrity in all of those. So we're not policy leaders in terms of intellectual property by any remote measure.
But there are many partners in mind who've been pushing us to be.
Yes.
So hopefully we'll get there. I'm sorry, Jack, did I interrupt you?
Jack's just pondering the whole thing. I have a question actually for Jack too, from one of our viewers, because we got another 13 minutes, so we want to make the most of them. Alfredo asked, what differences do you find, and it's the question on federalism and economics, Jack, so I thought you'd like it. What differences do you find in Canada's management of the COVID-19 crisis in terms of federal budgets versus provincial actions? How would you rate the response, the different levels of government to this?
I've seen a number of people saying, "Oh, we needed a national strategy. Federalism has been bad because it's led to a dysfunction between federal and provincial governments." I don't think that's been actually the problem. In fact, there's always some value to federalism, but the public health authorities amongst the provinces, there's been some variation in the way that they've handled the issue across the country. For example, the Atlantic provinces taking on a much different approach to controlling the spread compared to the other provinces. They can at least learn from each other doing that. But generally, the public health authorities really worked very hard and had to deal with what they did. I think the biggest issue I find is the fact that because the federal government public health authority does not administer the system, they don't have the knowledge or the information that they really need for good decision making, and in particular, the data that's required. And if I fault anything that we did in Canada, at least in terms of the federal provincial side, is perhaps the lack of getting all the data required. In fact, even in some of the provinces, and I know some stories, there was difficulty getting data as well amongst all the hospitals. And some of the decisions really depended very much on that. I'll give you an example. When you look at putting on health restrictions, because of their lack of tracing, and especially backward tracing, we don't know, for example, what were the sources of spread And so here governments were locking down restaurants, or they were locking down schools. Particularly schools is the one that concerned me the most. And they had, and they were really basing it on not knowing really where the source of the spread was. And I know that in the case of Alberta, they found that actually there was very little spread coming through the schools. That was not the problem. And so that's why they took the actions they did in not closing down primary schools. And I think that was the right decision for that reason. But we've really lacked that kind of information. And I think that's where the federal government, if they were going to spend the piles of money that they did, there should have been a lot more money going into tracing and in testing during this period. And part of that really required the federal government understanding better what was happening at the provincial level. Though there was a lot of communication amongst the provinces and the federal government, so that wasn't a problem. But it was more just really getting the priorities right and how best to respond to this situation that we went through.
And Jack, Audrey mentioned earlier, the need for us to invest in healthcare capacity on a go-forward basis. And I think an important element of that is digital infrastructure and data. And equally as important as physical capacity is going to be that digital infrastructure.
Great. Well, you're bringing us actually to our last question, which each of you will get a couple of minutes to answer. And that is, what do we do next? And what would you propose? You had to propose one strategy or one big idea to increase the environment, both for innovation and also for growth in the health and life sciences fields in Canada. What would you propose? What is not necessarily a magic bullet, but a piece that perhaps we've ignored, or something that we have learned through COVID really matters, which we didn't see before? So I could start. Jason, you're looking ponderous. Do you want to start us off on the conversation?
Well, geez, I'm having trouble thinking of one. I've probably got about.
You on data. That's why you made me think it's time to ask this question, because that is huge.
I've got about three that I would rattle off really quickly. Okay. One, stop what you're doing on PMPRB, rethink that. Number two, I mentioned the HBEST strategy, time to dust that off. And number three, I talked about the need for Canadian innovators to be able to access and be adopted into the health system. Many jurisdictions leverage their procurement, their health procurement portfolios and budgets to do that. And Canada still does not to a great extent. And we can do it within the means of our trade agreements. And we should start doing that. Again, not to become too protectionist here, but just to level the playing field a little and to help our innovators, to go global. We need to buy our own innovations.
Okay. When Mexicans don't buy Molson. I remember that book. All right, Audrey, I'm going to put it over to you. What would be your one big policy proposal, if you had the ear of our politicians right now, to improve innovation in the life sciences field?
Well, I'm going to, since Jason has set a precedent, I'm going to rattle off a couple of them.
Go ahead.
Some kind of a general agreement in trade and pharmaceuticals and PPE generally, so that we can ensure that, people don't slam the door and not give us PPE because they've got an outbreak in their place, that we've got reciprocal relationships to give us secure supply, to look at our public system and try to think about how to introduce and reward innovation within it. And thirdly, I would start thinking about more stable funding structure for our system as a whole, so that we're not constantly in a putting out fires situation.
Very well put. Richard, over to you. What's your big idea, or big couple or three ideas, that you think we should put forward to improve innovation in the life sciences sector?
Well, thanks, Tasha, for giving me that extra scope. I'm going to segue from Jack and Jason's excellent points about data gathering. It is unbelievable that we are still really without intelligence to fight this COVID war. The lack of responsiveness with which governments have failed to identify the data we need and go strong in gathering that data is staggering. I think in terms of a big idea, drop drug price controls, no PMPRB. That's the big one. And also, maybe even bigger is, and responding to Alfreda's great question, let's have a more competitive federalist approach. Let's take advantage of the fact that healthcare is governed by many jurisdictions in this country. Canada, the federal government, tries to stifle innovation by ensuring a consistent model of delivery across the provinces, to a certain extent, through the Canada Health Act. Get rid of that. Let's get the feds out of the picture, other than for funding, and let the provinces begin to find ways to innovate and compete with one another, as they should be.
All right. Jack, you get the last word on the question. What's your big idea?
Well, I was going to say I was going to rattle 10 ideas off, but the first 9 have been covered by Audrey and Jason and Richard, so that saved me time. I think I'm going to go back to one point I've said before, but it is a big idea and it requires a huge amount of change to the system. And that is, we need a much better integrated system in Canada. Integrated amongst the different functions, whether it's home care, long-term care, hospitals, physicians, and that does require sharing of data and all sorts of things that are to build that type of system. And I think that the approach that we need is to really do what the UK actually did quite well over the past number of years, which is to move to a much more integrated system in the UK. For the National Health Services as well as their private system, and we should not be afraid of having private supply within the public health system. There's nothing wrong with it. We're already doing that to a certain extent, and I think to the extent that this can help us develop more innovative practices, I think that actually could be a very positive step. But integration is really critical, I think, to help develop that innovation over time.
Okay, that's a very, I won't disagree with anything you just said in the last segment there, but we do have a couple extra minutes. So I want to ask, that's something that depends a lot on political will. So as a final thought, to generate political will for the kind of changes that we've been talking about here, whether it's reversal of PMPRB or expansion of private care within the system, or breaking down those barriers and encouraging regional innovation, where do we get this political will? How do companies, people watching today from the industry, how do they encourage that political will in Ottawa? We've got 30 seconds on each of you for your thoughts on that one. And Jason, I'll start with you. So we'll go back in the same order.
Yeah, it has to come from the general public. All of us have lived through COVID and what it's done to, our ability to connect with our families, our businesses, our communities, and the solutions are going to come from the life sciences industry. So collectively, we have to place value on life sciences innovation and tell that to our policymakers.
Audrey?
Yeah, I think it's the investment story that we have to push to get policymakers to understand. But I also think that we have to have incentive compatibility within our system so that we don't have cross purposes, hospitals saving, but then that doesn't benefit, or saving in the drug budget and not. We've talked about that. I don't want to rely on politicians to get us out of this, but I do think that our bureaucracy can marshal itself to take a look and see how to align the regulations in a way that would promote integration, because that's why we don't have integration. It's because we've got structures and policies and regulations that preclude it from occurring. And so that's where, we need to give much more attention, and a lot of the other things, including, data and all of that. Many other countries brought that in a long time ago, and they're publicly funded and everything. So the question we have to ask is, why has our system not been incentivized to introduce these data systems on its own?
Okay,
and take a look at that.
Richard, go ahead.
Yeah, I think it's a question of vision. I think everything everybody else has said is right, but I think there is an opportunity for fresh thinking, for a political vision that takes some of the ideas that we've all been talking about here. They're relatively plain and straightforward, and they really serve the interests of Canadians. They're not about helping industry against against the citizens or rich against poor. They're about actually creating capacity to serve everyone. They're about creating innovation that will in turn create wealth and better health outcomes for everybody. So I don't think it's a hard political sell, but the problem is that we don't have debate about these things. We have platitudes. In Canada, we're satisfied with platitudes. If our system were so strong, we have no reason to be afraid of debate. Let's have the debate. Let's discuss ideas and innovations. But alas, I don't share Audrey's faith that the bureaucracy is going to be where those seeds will grow. I think it's going to take a little bit more shaking up than that.
All right, Jack, you do get the last word. 20 seconds or less now.
I only get 20 seconds. Okay, that's fine. I would like to go back to Jason's first comment, was that politicians respond to voters ultimately. And we really have to get voters to understand that the pie is not limitless. And especially after this COVID experience, we're going to be short of funds, and we're going to need to look at if we want to have a better healthcare system, we're going to have to find very innovative ways to make it better, which is not going to cost a fortune. And to me, that means bringing in private participation a lot more into the system in order to provide the resources and the innovation that we're going to need.
Great. Well, thank you so much. I want to thank all of you, Jack Mintz, Audrey Laporte, Jason Field, and Richard Owens, for this great conversation. I want to thank the team also at the Macdonald-Laurier Institute, Alison Kerrigan, Brett Byers-Lane, David Watson, and Tom, who's been doing our audio here for some tough times. So thank you so much, everyone. My name's Tasha Carrot, and I'm going to sign off. If you want to see this entire broadcast, though, pieces you might have missed, don't worry, it's going to be on the MLI website. You can access the entire thing there. Thank you very much, and stay safe.